I think Kishore, we can start.
Yes, sir.
Just before you start, uh, as Dr. Ranjana is unwell, the same topic, everything about fluids would be taken care or would be addressed by Dr. Nandakishore, who is the consultant and head of Department of Critical Care from Pulse Heart Center. Over
Yeah.
to you, Kishore.
Good evening, friends. Today we'll be discussing everything about fluids. Having discussed how much amount of fluids to be given in the last class and what are the various methods of fluid volume resuscitation to assess the fluid responsiveness, we'll now come to uh, a methodology or like understanding of what type of fluids to be given. We already learned how much of fluids to be given, and now we'll learn about what type of fluids to be given. We all know fluids have been there in the armamentarium of our ICU in the last few decades, and we have been using them for intravenous fluid resuscitation for many patients. But there is a significant paradigm shift or a change in our understanding about the type of fluids. I mean, the way things have changed in the at least last 5 to 10 years. The way of understanding the fluids, like fluids, instead of causing more benefit, tend to also cause more harm. So, based on this dictum, my lecture will be divided. I will be discussing more about the various types of fluids. We'll be discussing more about the balanced crystalloids, how balanced they are, and normal saline. Is it a normal saline or an abnormal saline? Pretending to be normal, and hyperchloremia, which is a more fascinating thing when we give fluids to someone. Is it a real concern? And what is the evidence against the use of normal saline as compared to your balanced crystalloids? And we will try to slightly dissect the evidence in favor or against the favor of saline. And what is the role of colloids and albumin in our ICU as far as the fluid resuscitation is concerned? So my talk will predominantly be targeted towards these main topics. So the question comes, what makes an ideal fluid, or what should be the ideal characteristics of a fluid? So when we talk about fluids, an ideal fluid should be more physiological. I mean to say, it should have a similar properties that of a plasma or an intravascular fluid, and it should also be less toxic. I mean, it shouldn't cause more side effects. It should be easily available, less expensive, and more balanced. More balanced since in it should be more balanced in terms of its ionic composition, or in terms of its electrolyte composition, or in terms of its osmolarity. And it should also obtain a desired response when given without minimal side effects. So these all properties makes the fluid an ideal fluid. So let us see what are the factors which are more influential in making a fluid an ideal fluid. So what kind of factors should we think into uh, we should keep in your mind while choosing a fluid? So these are the main factors which determine or to say that a fluid is an ideal fluid. One thing is osmolarity. Second thing is the amount of oncotic pressure it's influencing over the endothelium. And third thing is the endothelial glycocalyx. What amount of damage is causing to the endothelial glycocalyx, leading to the extravasation of fluid into the interstitial space. And what is the strong ion difference? This strong ion difference has been now creating waves into the intensive care medicine. And this strong ion difference is known to be more physiological. Uh, there is a strong physiological rationale of applying this strong ion difference. And whenever we choose a fluid, the fluid consideration should be taken in terms of all of these aspects, considering its osmolarity, what amount of oncotic pressure it's going to exert, what amount of damage it's going to cause endothelial glycocalyx, and what is the strong ion difference. So I will discuss in detail about all these terminologies. So before going into the details, we need to understand the basic physiological aspects of the fluid compartments. We all know the total body water constitutes almost 50 to 60% of the body weight in men, as well as 40 to 50% of body weight in women. If you take an average 70 kg man, the total body water constitutes to close to 42 liters. In this, 1/3 is extracellular fluid compartment, that is close to 14 liters, and the rest is intracellular fluid compartment, that is 28 liters. Of this extracellular fluid volume, the interstitial fluid is almost 3/4, that is 10.5 liters, which as an intensivist, we are more worried about. The moment you give some fluid to the patient, if the patient has a leaky capillaries or an inflammatory response or many conditions as per se in the intensive care, this is the fluid which we are more concerned nowadays as a toxicity of fluid resuscitation. So when we talk about interstitial fluid is the space between the tissue or organs. It bathes all the cells in the body and is the link between the intracellular fluid compartment and the intravascular compartment. So it acts as a microenvironment that allows movements of ions, proteins, and nutrients across the cell barrier. When excess fluid accumulates, it leads to edema. So this is the most important fluid compartment. We are probably one tends to forget it or like neglect it, but this is the most important fluid compartment which we usually target in our day-to-day care. So the plasma is the only major fluid compartment that exists as real fluid collection all in one location and differs from interstitial fluid in its much higher protein content. So coming to the transcellular fluid, it is the extracellular fluid which is separated from the plasma and the interstitial fluid by cellular barriers. For example, your pleural fluid, ascitic fluid, your synovial fluid, and your cerebrospinal fluid. So the fluids, basically the transcellular fluid is meant to say the fluid contained within the epithelial line space. That is the third spacing. So this is also one more important fluid where we usually see after a 48 to 72 hours resuscitation of a critically ill patient. This is the component of or the compartment of the fluid which tends to get accumulated. So the electrolyte composition of the various transcellular fluids are quite dissimilar, but the interest of compartment for us, as far as intensive care is concerned, is not only the intravascular. You must be looking at extra interstitial fluid as well as the third space fluid, that is the transcellular fluid space. So coming to the other most important physiological aspect, that is the endothelial glycocalyx. People have thought probably 10 to 15 years back, the way they looked at fluid resuscitation was purely based on oncotic pressure, and the hydrostatic pressure. So they used to think that there should be a fine balance between the oncotic pressure and the hydrostatic pressure for the fluid to remain in the intravascular volume. But this entire concept was debusted by a nice physiological thing, that is the endothelial glycocalyx layer, which is a new barrier. So what is this endothelial glycocalyx? So how important it is for understanding of the fluid resuscitation? So basically it is a layer. It is a layer in the endothelial lining, which covers the endothelial lining, which is composed of a web of membrane-bound glycoproteins and proteoglycans together with bound plasma constituents. Physiologically active, it is a physiologically active endothelial surface layer with a functional thickness of over 1 mm. So what does it do? It basically maintains the vascular barrier function by preventing the large migration of the large macromolecules from moving across the endothelium. Basically, it tends to protect the endothelium. It prevents the leakage of the plasma proteins from the endothelium out from the endothelium into the interstitium. Not only this, it also prevents the leukocyte adhesion and platelet aggregation, thus reducing the inflammation and limiting the tissue edema. So basically, the glycocalyx is a protective barrier, and it's not only maintains the regulation of the intravascular volume, but also it helps in the mitigation of inflammation. So the glycocalyx is compromised, as we know, in certain systemic inflammatory conditions. So as we are thinking the age-old hypothesis, the traditional belief that the Starling's hypothesis, which used to tell that fluid used to leak in the fluid used to directly come from the arteriolar capillaries and from there into the interstitial space, and from the interstitial space the venous capillaries used to directly the fluid used to flow directly into the venous fluids based on the concept of oncotic pressure. But this probable Starling hypothesis was demystified because probably he didn't knew that there is a endothelial glycocalyx. This concept of endothelial glycocalyx is probably not known by Starlings, and transcapillary fluid loss actually seems to be limited by an oncotic pressure gradient across the endothelial glycocalyx. If you see the Starling concept, the fluid moves into the interstitium of the arterial side and then absorbed by the oncotic forces of the venous end, which doesn't usually occur as per the hypothesis suggested by endothelial glycocalyx. And this interstitial fluid doesn't directly move back into the vasculature. So a net pressure is maintained by the endothelial glycocalyx where there are tight endothelial cell junctions, and maybe the hypothesis of Starling, which he put forward, may not actually hold correct true in the present setting. So what is osmolarity? Osmolarity is another factor which influences your regulation of fluids. So osmolarity is a measure of those particles that are capable of exerting an osmotic force. So you need a certain osmotic force to maintain the blood inside the intravascular compartment and not going into the extravascular compartment. So what are the major, if you see the electrolyte composition or the osmoles, which regulate the osmotic force, they are the sodium, potassium, chloride, carbonate or the electrolytes, and the non-electrolytes being the urea, glucose, bilirubin, and albumin, which regulate the plasma osmolarity. So under normal situations, the osmolarity of each and every compartment, maybe it's an interstitial compartment or a plasma compartment or intercellular compartment, all are in a harmonious and equal manner. So coming to the strong ion difference, this is one more important concept which we all need to understand while choosing a fluid. So how does strong ion difference, what is strong ion difference, and how does strong ion difference make you choose a fluid? So strong ion difference basically is that if, when you see in a physiological pH, the cations and anions exist as a charged particles and dissociate from their partner ions. So these ions are strong because their ionization state is independent of the pH. No matter what is the pH, the ions are at a certain state of ionization irrespective of the pH. So strong ion difference is basically the difference between the strong ions, strong cations, and strong anions. The strong cations being the sodium, potassium, calcium, and magnesium, and the strong anions being the chloride and lactate. The weaker anions being the sulfate, phosphate, albumin, protein, etc. So the strong cations predominate in the plasma at the physiological pH, leading to a net positive plasma charge of approximately 40 to 45. So if you calculate the strong ion difference, obviously the sodium, potassium, calcium, magnesium, it's close to 160. And the chloride and lactate, there is a difference between plus 40 to 45. So according to the law of electroneutrality, the sum of positive charges should always be equal to the sum of negative charges. Therefore, the strong ion difference must be equal to the sum of weak anions in the body, such as the bicarb, albumin, and phosphate. So the physiological solutions, those causing neither acidosis or alkalosis, require a strong ion difference approximately of 40 to 42. So how this strong ion difference will help you in choosing the fluids? So if you see the electroneutrality equation, this is the strong ion difference. It should be at least around 40. So physiological solutions require a strong ion difference of approximately 40 to 42. So if you calculate the strong ion difference of 0.9% saline, it is 154 sodium minus 154 chloride, that is 0. The strong ion difference of NS is 0. At the same time, the strong ion difference of ringer lactate is around 24. It's 131 sodium plus 4 potassium minus 111 of chloride. That is equal to 24 milliequivalents. And the strong ion difference of plasmalate comes close to 47, which is probably close to that physiological range of strong ion difference of 40 to 42, making it more a physiological solution. So let us go into the detail of each and fluid later. But I want you to understand that when you try to select a choice of fluid, probably you assess the patient, you see the strong ion difference, you do an arterial blood gas analysis and electrolytes. You first calculate the strong ion difference, and based on that strong ion difference, probably it's worthwhile choosing a solution. So coming back to our discussion, what is an ideal fluid based on these 4 parameters? When you put these 4 parameters together, when you put the osmolality, when you put the strong ion difference into picture, when you try to understand the position of the endothelial glycocalyx, you know if there are leaky capillaries. For example, if patient has a septic shock, you know the capillaries are leaky. You know there is a damaged endothelial glycocalyx. For example, there is a patient of acute pancreatitis or a dengue shock syndrome where you again expect your endothelial glycocalyx to get deranged. So you need to understand the subset of patients which you are dealing with so that you know whether the endothelial glycocalyx is probably damaged or not. And based on that, and apart from this understanding of your osmolarity and your strong ion difference, you put all these two together to check an ideal fluid. So you need a fluid whose osmolality is equal to plasma, number one. It should be isotonic. It should cause less harm to your endothelial glycocalyx and stick to the ionic distribution rule. And chloride should be equal to plasma. And the chloride of the content of the fluid should be equal to plasma. And the strong ion difference should be more than 0, but less than the plasma. That means it should be more in the physiological range, that is around the 40 figure. So, and it should not cause only volume expansion, but should also leak less into the interstitial space. So for me, if you ask me what is an ideal IV fluid, probably these are the parameters where I would look onto. I would look onto whether the osmolality is equal to plasma, whether the strong ion difference is more physiological, whether it causes less damage to the endothelial glycocalyx, and whether the fluid expansion is adequate, but at the same time leaks less into the interstitial space. So this is about selecting an ideal IV fluid. So let's see what are the types of IV fluids which are present in our armamentarium as far as our daily intensive care practice is concerned. So the types of fluids, the crystalloids and colloids, as we all know, crystalloid solutions contain low molecular weight salts or sugars, which dissolve completely in water. They pass freely between the intravascular and interstitial compartments. So the probability of them staying in the intravascular compartments for a longer duration of time is a little bit less. When compared to colloid solutions contain a larger molecular weight substances. They do not dissolve completely. And depending on their molecular size and the structure and the permeability of the capillaries of the patient, they remain for a much, much longer period of the time in the intravascular compartment. So the crystalloids, coming to the crystalloids, we know there are isotonic crystalloids, hypotonic and hypertonic crystalloids. The isotonic crystalloids, we have normal saline, the ringer lactate, the balanced solutions like plasmalite, hypertonic saline, the hypotonic solutions like your 5% dextrose. So these are the various electrolyte composition of the commonly available crystalloids. I have compared saline, ringer lactate, plasmalite, and stereophonin along with your normal plasma. If you look at the composition, the sodium of all the fluids is almost close to around 140, except sodium, normal saline, where the sodium is extremely high, it's around 154. And if you see the chloride content as well, the chloride content of sodium is also a little bit high. If you see the chloride content of ringer lactate, it's around 111, and that of plasmalate is around 98. If you take the plasmalite, the one more important thing for the plasmalite is there is acetate of 27 millimoles per liter, not in the form of bicarb or not in either the form of a lactate solution. So coming to normal saline, it is neither a normal solution or a balanced crystalloid. It contains 9 grams of NaCl in 1 liter. and the pH is around 5, contains sodium of 154 milliequivalents and chloride of 154. Osmolality is 308, and hence the sodium and chloride dissociate only partially. It's around 0.926% where they dissociate partially, and probably that is why it is probably called as isotonic saline. And the strong ion difference, if we calculate, is 0. So saline administration, the expansion of intravascular volume persists for as long as 6 hours after infusion. It can cause dilutional hyperchloremic acidosis, which is of major concern. I will discuss it in the next coming slides. Administration of fluids with a strong ion difference of 0. What happens when you administer saline? Why you are more concerned about calculating the strong ion difference? So you know the strong ion difference of saline is 0. And what happens when you administer such fluids with a strong ion difference of 0? It will lead to dilution of plasma, leading to a decreased strong ion difference. So decreased strong ion difference in the sense leads to acidosis. So hyperchloremia along with a reduction in the strong ion difference may lead to acidosis. And hyperchloremia when saline is administered causes renal arteriolar vasoconstriction, leading to a reduced reduction in the GFR and ultimately the decreased urine outputs. So the peak effect of this hyperchloremia occurs after infusion of the saline after few hours and effect normalizes in 1 or 2 days. So the more and more initial fluid resuscitation of choice you choose will be a normal saline, the more peak effect that you can see a hyperchloremia or a reduction in the strong ion difference. So what are the adverse effects of IV administration of saline? As I told, it can lead to hyperchloremic metabolic acidosis. This is a metabolic complication. And there is a clear evidence stating that it can also lead to your damage in the endothelial glycocalyx. There was a small study done by probably a pilot study done in around 200 patients where they looked at administration of saline leading to what's happening to the capillary leak or the damage of the endothelial glycocalyx. And they found that the more saline we give, the chloride and sodium tends to cause more release of natriuretic peptides, leading to then these natriuretic peptide again causes the damage of endothelial glycocalyx, leading to the extravasation of this fluid into the interstitial space. So there is an evidence to tell that normal saline can also lead to a damage in the endothelial glycocalyx, leading to more third spacing. And also it leads to ILS. It's a part of a global increased permeability syndrome. And this, as a part of this GIPS, it can cause increase in the GI edema, the ILS, and all. And there is one more small study coming from the surgical unit telling that it also increases the intraoperative blood loss as per the hematological thing is concerned. In those study, they have mentioned that what has been the effect of saline on the RBCs. The more saline you give, the RBCs get deformed. The RBCs imbibe more amount of fluid and they get deformed, and this leads to hemolysis. And they have clearly showed that there's an increased intraoperative blood loss when you use a normal saline. And apart from this, there are more other most post-operative complications in terms of clinical outcomes, more mortality and resource utilization, and also the incidence of AKI and requirement of RRT has also been shown to be tremendously increased with your effects of normal saline. So these are the various adverse effects of IV administration. So though it is called an isotonic saline, for me it's an abnormal saline, and because of its toxic side effects, and it doesn't appear to be having a strong physiological rationale. So apart from the 4 things I have told, the osmolarity, the isotonicity, the damage to the endothelial glycocalyx, and the strong ion difference, it stands not as an initial fluid of choice because it has many of the side effects. So what are the effects of hyperchloremic acidosis? So if you see the renal function, what happens when there is an increased chloride load? The moment when you give a bolus of 1 liter of saline to a patient, there is an increase in the chloride load. This increase in the chloride load at the proximal converted tubule will cause a reduction in the GFR. How does it happen? when the chloride load is more, the macula densa cells present in the glomerulus get stimulated, and this will in turn release your renin angiotensin, or the renin angiotensin gets activated, leading to an increase in the causing the renal arterial vasoconstriction. This renal vasoconstriction reduces the renal blood flow, leading to a decrease in the GFR. But does it actually translate into an increase in creatinine and increase in the incidence of AKI? We are not sure. So, what are the effects of hyperchloremic acidosis? The renal function, there is no significant increase in the creatinine, but there might be a slight increase in the early biomarkers like your NGAL, which was seen, but it was not clinically very significant. So, we will come to that evidence in the later slides. What happens to the coagulation and bleeding? There is no significant detrimental effect on the coagulation and bleeding as far as hyperchloremia is concerned. And regarding the gastrointestinal function, you can see a little bit of nausea, but vomiting is not significant. And mortality worsening base deficit, but not associated with increased mortality. There has been a small meta-analysis comparing different studies, which showed that when you use normal saline compared to your balanced crystalloids, your base excess has significantly increased and your GFR has significantly decreased. So, but still no proven evidence to shift from saline-based solutions to a balanced solution based on the only effect of hyperchloremia. If you are showing a person that I don't want to use saline based only on hyperchloremia, we may not be exactly justified. So does it have any clinical implication? This was the evidence I have been talking about. The JAMA publication and the post-op intensive care publication has been done. This is a perioperative association with morbidity. And the less the chloride levels in the post-operative period, it has clearly shown the difference in the post-operative morbidity. And Shaw et al. At the perioperative morbidity and mortality, it has shown that hyperchloremia has increased the longer duration of stay, more RRT requirement, and more resource utilization. You can see the forest plotting. It has been shifted towards the favoring the balanced crystalloids. And the most important thing as far as intensive care is concerned is the increased requirement of the RRT and increased incidence of AKI. This study has been published in 2008-9 in the JAMA, and it has clearly told that it has clearly compared chloride restrictive versus chloride liberal fluid strategy. If you apply this strategy, you may found an increased incidence of acute kidney injury and the increased requirement of RRT in patients receiving more chloride solutions. So this is the evidence, and based on this evidence, it is probably our time to change the practice and probably start judiciously using your normal saline. So what's the evidence against saline-based resuscitation? So far we have an evidence to tell that NS, so saline can cause increased incidence of AKI, or saline can cause hyperchloremia. But what is the evidence that is actually against saline-based? This evidence comes when you compare your balanced crystalloids with your saline. So this is the earliest study which compared balanced crystalloids with saline. In non-critically ill adults, the earliest trial were the SALTED trial, and in critically ill adults, it was a SMART trial, which is a cluster randomized control trial done in almost patients receiving in almost patients of 5 ICUs. The conclusion was, in the SALTED trial, there was no difference in the hospital free days between the balanced crystalloids and the saline. And if you see the incidence of AKI stage 2 and mortality, there is slightly borderline, and they didn't find any major difference between the both groups. The incidence of AKI was almost equal in the both groups. But this SALTED trial was majoritarily conducted in non-critically ill patients. If you see the SMART trial, which is majoritarily conducted in the critically ill patients, they concluded that use of balanced crystalloids resulted in a lower rate of new onset major kidney adverse events than the use of saline. So if you are using a saline, the incidence of your adverse kidney events were more, close to 15.4% than your balanced group. So this study was not sufficient enough because it was done in a less number of patients, and people looked over to another study, that is a basic clinical trial, which is a double-blinded trial conducted in over 75 ICUs in Brazil over a period of 3 years. And basically, the primary outcome which they studied was the 90-day mortality. They differentiated the patient into two arms, mainly the balanced steroids and the normal saline group. And in that also they have again did two subgroups, two specific arms. One is the high infusion rate and the low infusion rate. So in the plasma-lite group, 26.4% patients had died at 90 days compared to the 27.2. There was no statistically significant difference in the overall primary outcome. And whereas the secondary outcomes is concerned, the incidence of AK requiring RRT on day 1, 2, 3, and 7 was also not significant difference between both groups. And if you see the individual total SOFA scores also, there was not much significant difference. But if you see the individual organ SOFA scores, the incidence of neurological SOFA was more than 2 on day 7 and was significantly higher with plasma-lite compared to the normal saline. This again tells you that probably your choosing of fluid also depends on your pathology. If you are choosing a fluid for a patient with a traumatic brain injury or a neurological insult, probably choosing a normal saline is a much more common sense in using over preferring a solution like a plasma-lite. And this study again, the major backdrop study is majority of them included the post-operative surgical ICU patients. And on one pre-specified subgroup analysis in patients with traumatic brain injury, the 90-day mortality rate was higher in the plasma-lite group compared to the normal saline group. So this study showed us that probably there is not of much significant difference in the balanced crystalloid group versus your saline as far as the mortality or your SOFA score is concerned. But definitely, yes, you can choose these solutions based on your subset of patients or on the various pathophysiological aspects. So coming to the Ringer lactates pH is around 6.5. The strong iron difference, if you calculate, is 28. If you see the composition of Ringer lactate, sodium is 131, chloride is 109, lactate is 28. The osmolarity, if you see, is 273. So with a chloride equal to plasma and a strong iron difference more than 0 and less than plasma, it is an ideal fluid. So probably your strong iron difference is as close to the physiological range. And if you see the entire composition, almost the osmolarity, everything matches with that of the plasma. And probably this is probably an ideal IV fluid. Lactate is used instead of bicarb because it is more stable during the storage, and lactate readily gets converted into bicarb by the liver. So our major concern was the presence of lactate. The moment we see Ringer lactate, somebody holds back looking at the lactates. Already you have a patient who is sick, whose lactates are elevated, and still you get a doubt that probably giving this Ringer lactate would cause a harm. There was a small study, double-blind control trial, which was published in 1997, the effect of Ringer lactate infusion on the circulating lactate concentration. And they found that infusion of Ringer lactate in normal adults who are hemodynamically stable does not increase circulating lactate concentrations when 1 liter is given over 1 hour. I don't know how they came to a conclusion of 1 liter over 1 hour, but they clearly showed that there was not significant increase in the circulating lactate concentration even when you give a Ringer lactate solution. So can you give Ringer lactate in shock and hepatic failure? We all know the liver is a major organ which metabolizes the lactate. So in critically ill patients whose lactate clearance is 0, exact effect is not known. And 1 liter of Ringer lactate, if mixes with 5 liters of blood volume, may increase the lactate by around 4 points. This is just a theoretical assumption. So, but only 25% of Ringer lactate stays in the intravascular space in normal patient, and in critically ill, it is even less because of the increased permeability. So Ringer lactate can safely be given even in patients with impaired lactate clearance. So if you apply the logic or funda of this theoretical hypothesis that only some amount of volume at the end of the day, all the crystalloids will not stay in intravascular volume for more than 3 hours. So if you think that only 25% of your Ringer lactate stays in intravascular space at the end of 1 hour, so probably, and if the critically ill patients, there is an increased permeability, and even if you calculate in this way, Ringer lactate can may safely be used in patients with your impaired lactate clearance. So, is there anything which hampers your leukocyte inflammation and there is any correlation with your ringer lactate and your leukocyte thing? So it has been published in multiple studies. There is an evidence telling even in the Journal of Trauma, and she's saying that effects of ringer lactate solutions on the human leukocytes. It's commonly used formulation influences neutrophil function and leukocyte gene expression. And lactated ringer solution reduces the systemic inflammation compared to saline in patients with acute pancreatitis in a small study which was published in Clinical Gastroenterology and Hepatology. So ringer lactate probably also mitigates the inflammation. If you see the endothelial glycocalyx, there is a role of mitigating inflammation. So probably ringer lactate is probably doing a small favor in terms of mitigating inflammation. So coming to your favorite plasmalate composition, plasmalate, the electrolytes being sodium 140, potassium 5, chloride 98, the acetate is 27 and the gluconate is 23. If you calculate the strong ion difference, it's coming close to 47, which is the physiological range. It contains sodium chloride, magnesium chloride, potassium chloride, and sodium acetate. The pH is 7.4 and the osmolarity is 294. So plasmalate infusion, increased strong ion difference occurs with infusion. If you see the normal strong ion difference, the physiological range is around 40 to 42. So the strong ion difference of plasmalate is close to 50. So when you give plasmalate, there is a chance that the strong ion difference can increase, which can lead to a theoretical or probable chance of metabolic alkalosis. But there is no proven additional benefit of plasmalate over ringer lactate when compared. So the acetate which is present in the plasmalate is associated with pyrophosphate accumulation at times and inside the mitochondria and can probably lead to mitochondrial dysfunction. And this is also a theoretical possibility. And the gluconate which is present in the plasmalate is probably the reason for sometimes patients getting a false positive galactomannan test. So these are the caveats of plasmalate infusion, but this should not stop you from using the plasmalate solution. And the contraindications of plasmalate I mean to say it's a relative contraindications: hypernatremia, hyperkalemia, renal failure, existing renal failure, heart block because the potassium concentration is high, the metabolic and respiratory alkalosis because it again leads to metabolic alkalosis if infused in a very high dose, hypocalcemia and hyperchlorohydria, concomitant use of potassium sparing diuretics, which can again lead to hyperkalemia. And there is no adequate data for the safe use of plasmalate solution for infusion in pregnant and lactating women. So this is about crystalloids. And coming to colloids. So colloids are the fluid that contains solutes in the form of large proteins or other similar sized molecules with a very high molecular weight. So largely they remain in the intravascular compartment due to the oncotic pressure that is exerted or generated by their high molecular weight proteins or whatever. So the greater the intravascular persistence compared to the crystalloids, they have the intravascular presence for a longer period of time. This property is lost when capillary membranes are altered in disease state. For example, if your endothelial glycocalyx is damaged, obviously these solutions also will leak into the interstitial compartment. So the naturally available colloids being the human albumin, and the artificial colloids are the gelatin, dextran, and the starch solutions. So these are the electrolyte composition of the commonly available colloids in the market. And if you again see the sodium content of all these colloids, including the jello fusion or an albumin or a starch solutions, is enormously high in sodium and chloride content. So the characteristics of the colloids: albumin, the naturally available colloid, is a monodispersed molecule. That means all molecules inside the solution have a similar molecular weight, whereas compared to the other crystalloids like your dextrans or your jello fusion or your gelatins or starch solutions, they are a polydispersed, a wide range of molecules with a wide molecular weight. So they have a normal osmolality, and half-life depends obviously on the molecular weight and the elimination route and the involved organ function. So degree of volume expansion is predominantly determined by the molecular weight. So the other characteristics are the duration of volume expansion depends on the elimination of the colloid. And the gelatins have the shortest duration of volume expansion among all the colloids. And the sodium content of colloids is similar to that of crystalloids. But the potassium content difference, it is slightly lesser than the crystalloids. And albumin and gelatin solutions have physiological pH, while other solutions tend to have an acidic pH. So coming to albumin, we all are fascinated about using the albumin. I mean, whether to use albumin or not to use albumin, and what conditions to use albumin is the debate of the present day. The albumin principal natural colloid, which is available as either 5% or 25%. It comprises 50 to 60% of all plasma proteins and contributes to 80% of the normal oncotic pressure. And the molecular weight of 69,000 daltons synthesized only in the liver and secreted into the bloodstream. 42% of this remains in the intravascular compartment, and the half-life is huge. The moment you give albumin, it probably tries to stay in the intravascular volume for up to 20 days in a normal healthy volunteer. So the albumin 5% solution is isooncotic and leads to 80% of the initial volume expansion. And if you take a hypertonic albumin that is 25% solution, it leads to 200 to 400 increase in the volume within 30 minutes, and the effects persist for 16 to 24 hours. So the advantage, it's being a natural colloid, 25% albumin has a greater degree of volume expansion as compared to rest of the colloids. Still remember a paper comparing the initial fluid resuscitation of choice as a 5% albumin in the Paul Merrick paper, where he used a fluid challenge of 5% albumin, taking 250 ml of 5% albumin, shown to have effective volume expansion compared to your crystalloids. And probably this hyperoncotic has a double expansion compared to your 5% solution. Principal binding protein of endogenous exogenous substances, and also has some antioxidant and potential oxidant scavenging effect. So the disadvantage being it is expensive. And what are the indications of albumin? As far as ICU is concerned, I personally probably use albumin in only 3 of these conditions. Probably following a paracentesis, large volume paracentesis, which we regularly do in a CLD patient with a gross ascites, in patients with liver cirrhosis for extracorporeal albumin dialysis, and probably after liver transplantation. And albumin has also shown to reduce or have a mortality benefit in patients having a hepatorenal syndrome. Probably it will delay the process of hepatorenal syndrome, or it will prevent the patients progressing or deteriorating in patients having hepatorenal syndrome. And as far as fluid resuscitation of choice is concerned, so surviving sepsis guidelines tell that it can be used as a fluid resuscitation of choice after the early phase, that is a 48 to 72 hours of the phase of early resuscitation with crystalloids. Even the patient, if you think, can take some fluids, you can try albumin after 48 to 72 hours. This is a thing which is directed by the early cold therapy. But I personally feel that albumin probably causes more harm when you try to give as a fluid resuscitation of choice. And the current day practice, it doesn't hold as a fluid of choice for resuscitation, but probably you can use it or explore it for different options. So what is the evidence for albumin in comparison with your crystalloids? There's a famous study, the SAFE study, which is published in 2004 in EGM, and the Albert study. If you see the SAFE study, it's a comparison of albumin and saline for fluid resuscitation in intensive care unit to compare the effects of two resuscitation fluids. One is the 4% human albumin or the saline on 28-day all-cause mortality in the ICU patients requiring intravascular volume resuscitation. The hypothesis they put forward is the no difference in the mortality at 28 days. So what exactly this study conclude? This study draw a conclusion that in heterogeneous population of ICU patients, albumin and saline are clinically equivalent. It doesn't matter which fluid you choose, both have same effect. Use of either the albumin or saline resulted in similar mortality. There was no mortality difference. Similar time to death in those who die. Similar use of mechanical ventilation and renal replacement therapy. There is similar incidence of new organ failure and similar length of stay in the ICU and hospital as well. So the only difference they observed was probably in patients with trauma, with or without traumatic brain injury. If you see this bar graphs, you will understand that in patients with trauma, probably the use of albumin slightly reduce the mortality when compared to without trauma. And in that also, trauma with traumatic brain injury, probably use of albumin was detrimental. If you use the saline group scored more than the albumin group, and saline had clearly a decreased mortality when compared to your albumin. And this tells you that albumin be uh, should never be used in patients with trauma or traumatic brain injury. So this is a clear take-home message from the SAFE study that telling that albumin is detrimental, especially compared to saline, especially in these subset of patients where with a trauma with or without traumatic brain injury. Coming to the more the further study, there's the albumin albio study, which came from Italy. The comparison of 20% albumin and crystalloids for resuscitation of fluid. The major change which they made compared from the SAFE study, but they targeted a value or a magic number of 3 grams of albumin. So that means they resuscitated the patients with albumin to bring them to a target level, to achieve a target level of albumin of 3 grams. So they concluded that the use of albumin in addition to crystalloids to correct hypoalbuminemia as compared to crystalloids alone in severe sepsis did not provide any survival benefit at either 28 days or 90 days despite improvement in the hemodynamic variables. So if you see, there was not much significant difference in the outcomes and mortality, but they found that albumin group had a significant higher max in the initial days and lower heart rates, low net fluid balance, lower average cardiovascular SOFA scores. In the time of suspension of vasopressor, they could wean off the vasopressors much earlier, and there was slightly higher average individual organ SOFA scores, whether it's compared to liver or the coagulopathy. In terms of the albumin group scored slightly higher average SOFA scores compared with your saline group. So these are the conclusions which they made, and from these two studies, we can understand that probably albumin should not be used probably as initial fluid of choice, but can be tried when the patient has already completed his early fluid of resuscitations completely with colloids, and probably it can improve your SOFA scores, cardiovascular SOFA scores. It can reduce your vasopressor requirements as a temporary phenomenon, but ultimately you may not achieve the desirable outcomes what you need. So dextran, coming to the dextran, is another colloid, highly branched polysaccharide molecules. Basically, it is directed from the bacterial enzyme called as dextran sucrase. It is available as with a molecular weight of 70,000 daltons as well as 40,000 daltons. Primarily excreted by the kidneys, and the dextran 40 and 70 lead to a higher volume expansion as compared to your starch solutions and 5% albumin. So the duration of volume expansion lasts for almost 6 to 12 hours. So coming to the advantage of dextran, it causes volume expansion, and not only volume expansion, it improves the microcirculatory flow by two mechanisms. That is, decreasing the viscosity of the blood by hemodilution and inhibiting the RBC aggregation. It reduces the RBC aggregation and also causes hemodilution. Disadvantage being anaphylaxis is the major disadvantage. Many people have anaphylaxis to these compounds. It can lead to coagulation abnormalities. And of course, it can cause precipitation of acute kidney injury. So the indications, as of now, dextran doesn't hold any indication as far as intensive care is concerned. It is not the initial fluid resuscitation of choice which you look forward, but it is more likely to go into the surgical side, and it is mainly used in the surgical cases to improve the microcirculatory flow, especially in the microsurgical reimplantations, and also probably during the extracorporeal circulation during cardiopulmonary bypass. So coming to the gelatins are the proteins formed from the connective tissues of the animals are boiled. This is basically hydrolysis of the collagen tissue, which are taken from the animals. So that they dissolve in hot water and forms a jelly kind of thing when cooled. So the early solutions have a significant increase in the molecular weight. They have a very, very high molecular weight, close to 1 lakh dalton. And this had the advantage of a significant oncotic. The more the dalton or the higher molecular weight, the more is the oncotic pressure exerted by the fluid in the intravascular space. This is a theoretical thing, and based on this, they developed these gelatins. And the disadvantage of this is they are highly viscous and they have a tendency to gel out. So the newer generation gelatins, the gel fusion or the plasma gels, they are succinylated and modified fluid gelatins. To reduce this viscosity, they have slightly modified these gelatins. There are other ureal cross-linked gelatins like the polygelin and the oxypolygelatins, the gelofundin, which are rapidly excreted by the kidney. Its peak plasma concentration falls by half in 2.5 hours. The gelatin leads to 70 to 80% of the volume expansion, and the duration is shorter in comparison to both albumin and starch solutions. So the indications of newer generation gelatins, probably hypovolemia due to acute blood loss, where you don't have the provision of your blood bank, where you think that the time is short for getting the blood products. You can try these newer generation gelatins to achieve good intravascular volume. And acute normovolemic hemodilution conditions like acute normovolemic hemodilution you can try. Extracorporeal circulation, especially cardiopulmonary bypass and volume preloading prior to regional anesthesia. These are the indications where you can use gelatins. But as far as ICU is concerned, they are not the initial choice of fluid resuscitation. So what are the advantages of new generation gelatins? They are cost effective. They do not have any upper limit of volume that can be infused as compared to starches and dextrins, and lesser renal impairment as compared to your starch solutions, and lesser anaphylactic reactions as well. And disadvantages, they have coagulation effects, which is not very much clear. They tend to increase the bleeding time. They have shown to cause impaired platelet adhesions, and they can increase the plasma reading activity as well. Coming to the starch solutions, 10 years back, the starch solutions have been used left and right, even in the intensive care. And after much evidence, they found that starch solutions are actually harmful and can cause acute kidney injury. And this led to their degeneration in the intensive care unit as far as initial fluid resuscitation is concerned. Basically, these are derivatives of the amylopectin. They're highly branched compound of starch. Amylopectin structurally resembles glycogen, and it is rapidly hydrolyzed with a half-life of about 20 minutes. So to make the amylopectin molecule more stable for a sustained effect, they are substituted with a hydroxyethyl group. Hence comes the name as hydroxyethyl starch. So basically they are starch solutions. So it comes as a concentration of 10%, 6%, and the average molecular weight is 70 kilodaltons or 200 kilodaltons. And the higher the degree of molar substitution, the greater the resistance to degradation, and consequently, the longer its intravascular persistence. And the infusion of hydroxyethyl starch, there is an initial rapid amylase-dependent breakdown and renal excretion, and the plasma half-life is 5 days, and 90% is eliminated in 42 days. In a small study which has been published in NEGM, they found that this starch they have done kidney biopsy in patients who developed acute kidney injury after a 90-day course in the hospital stay. And they found that these patients had the starch present in their kidney for almost more than a year. So this tends to tell that these hydroxyethyl starch solutions can accumulate inside the renal tubules and can cause permanent renal damage. And they should be excluded when patients having an acute kidney injury. So these starch solutions increase in colloid oncotic pressure. They obtained with the increase in the colloid oncotic pressure is almost equivalent to that of the albumin, and it results in 100% of volume expansion similar to 5% albumin. And they are shown to have some anti-inflammatory properties as well. Advantage, it is less expensive than albumin, and the maximum allowable volume is almost 50 ml per kg, and which is greater as compared to other synthetic colloids. So what are the evidence about of when compared to this starch solution for the crystalloids? So the big three trials, the TEST trial and the BICEP trial and the SUCCESS trial, all these trials have shown that probably you shouldn't use starch solutions as your initial fluid of choice in the intensive care unit. and they didn't show any difference or change in the outcomes or the overall mortality benefit. In fact, they caused more harm in terms of increase in the incidence of acute kidney injury and increase in the need for the requirement of RRT. So the disadvantages, as I told, renal impairment is the most important thing. It can cause coagulation abnormalities and anaphylactic reactions. So the take-home message from this class is probably fluid should be administered with the same caution as any other intravenous drug. So the dictum is fluids are nothing but drugs. They have to be taken or administered same caution as any other drug. Like the 4D approach, the right drug, the right dose, the right duration, and whenever needed, the de-escalation. The right drug, that means the right choice of fluid, whether it's a balanced crystalloid or an abnormal saline, whether the dosage, what amount of fluid are you giving, because more amount can harm the patient, and the duration, how long are you going to give the fluids? Is it the first 24 to 48 hours? There is no role of maintenance fluid except in some conditions, and the duration itself decides the toxicity of the fluids. And of course, the de-escalation, you need to know when to stop the fluids or when to actually drag out the fluids. So this 4D approach should be made as far as any fluid resuscitation is concerned. Identify the fluid that is most likely to be lost and replace the fluid lost in equivalent volumes. And if you see, you know what amount of fluid is lost. For example, the patient has burns. You know what amount of fluid is lost. What is the probable replacement fluid you can give in an equivalent volumes. So, and also consider these four factors: what is the tonicity, what is it causing to the strong ion difference, and what is it causing to the endothelial glycocalyx. And consider the serum sodium, the osmolarity, and the strong ion difference. And cumulative maintenance fluids can cause interstitial edema. Please stop using maintenance fluids in the ICUs. The only indication for maintenance fluids in the ICU is probably the diabetic ketoacidosis and acute pancreatitis and burns, that too in the first 48 to 72 hours. And isotonic balanced salt solutions are a pragmatic initial resuscitation fluid for the majority of the acute ill patients. Thank you.
Thank you, Kishore. I think it was an exhaustive review. Summarizing what is, where each fluid stands and where each component of each fluid stands. Saline, of course, has been the first fluid ever developed, and it has withstood the test of time. Although people believe it's unphysiological, it still has become the mainstay of fluid therapy. A lot of people use it, but not. While we understand that chloride is dangerous and chloride is the main poison that saline contains, its effect on sodium balance also has to be looked at, because hypernatremia is also an important issue in the intensive care units. And it perpetrates fluid balance, volume overload and fluid balance issues and all this. So it is important for us to understand the role of sodium also in the whole thing when we are giving saline for these patients. End of the day, I think each patient has to be individualized, and fluid therapy also has to be individualized to avoid positive fluid balance and volume overload. And that's what we will discuss next week. How after fluid resuscitation, how do we de-resuscitate patients who have got a lot of fluids and a lot of positive balance? What is the effect of cumulative positive balance, and what are the strategies for de-resuscitating is something we'll discuss next week. And that will be done by Dr. Lavanya. Ghanshyam, you want to add something?
Just a couple of points. As Dr. Nandakishore and Dr. Srinivas have said, there is absolutely no doubt about the fact that fluids cannot be taken lightly. At the same time, we cannot label that one fluid is better or one fluid is bad. I think there are a wide range of clinical situations where each fluid has a definitive role to play. For example, if you see a patient with say a traumatic brain injury or a patient with metabolic alkalosis, probably NS would still be the first fluid of choice. Traumatic brain injuries, obviously, you don't want to give hypotonic fluids, and you want to have either a normal or slightly hyperosmolar fluids. Similarly, patients with severe metabolic alkalosis, you would be careful in giving plasmolytes, which can further complicate your metabolic alkalosis. Uh, then, on the contrary, if you have patients with severe sepsis, septic shock, where you're giving large amounts of fluids, maybe avoiding saline would be a better choice. So, I think each fluid had its own pluses and minuses. You need to identify the clinical scenario and the clinical indication why you're going fluid, why you're going to give fluids, and then probably based on that, choose a fluid which will fit into that context for your patient. So that's just one thing that I want to add.
Okay. So we will all meet again. Please do join us next week for the session on de-resuscitation. And if you have any queries or comments on this particular session, please do post those queries on the group from which you got the link to attend this session. And the speaker and one of us will try to answer those questions to the best of our abilities. So subscribe to our YouTube channel if you want to revise and recollect what Nandakishore has already uh, spoken. Please do subscribe to the YouTube channel. All the past videos of this Tuesday morning sessions are also uploaded on that session. And also to remind you, on the 24th of this month at 7 p.m., the Higgs Journal Club is also on, and you will be getting the links shortly on the same groups on which you got this link. Please do join for the Journal Club as well. Thank you very much. Have a good day.
Thank you, everybody. Thank you, Kishore.
Thank you, sir.